I did my psychiatry residency. I then did a fellowship in psychiatric drug development at Drexel and Janssen, and I was commuting over to Trenton to be at Johnson & Johnson. And after that, I was at the FDA and then another pharmaceutical company, and then I kind of got rid of the whole thing and started just doing deprescribing. And now, I live with my family in Park City up in Utah, and we just do this remotely, kind of all over the country now, in like 10 different states.
We have a very similar story and a very similar approach, just from a different angle. So it's kind of interesting. I've watched a lot of your stuff. I really like it. The what you're kind of saying, and don't let me put words in your mouth, but that you went through the normal medical process for psychiatry, and you started seeing stuff that you didn't necessarily agree with, so you went your own approach, and that's where I was at for physical therapy. Is that I did I graduated, I did all my specialties, and then I just started seeing like the wrong treatments, the wrong diagnoses, and the wrong treatments because of the wrong diagnoses. And so then I started doing my own thing, and now I treat a lot of remotely, like kind of all over the world. So I feel like we're in a pretty similar path here.
No, it's kind of scary when you realize that the standard of care is just, it doesn't actually help people. It just kind of, in many ways, makes people sicker, and then they just like churn through the system again and again and again.
Well, and
that was my impression.
And not only that, they keep getting diagnosed based off their symptoms that are often caused by the previous treatments. So, and I think you talk about that. You're seeing some people that are, they're on medication, and that medication is causing these side effects, and then they're getting other diagnoses or medications based off of those symptoms.
Totally. Yeah. I mean, we have some people, one of the ladies I work with, Trudy, was, getting ECT and antipsychotics for 20 years, and it messed her up. And like, it caused a whole bunch of weight gain and all these problems and metabolic issues. And this isn't for everyone, but for her, the issue was diet. She stopped eating gluten, and a lot of her symptoms improved. And well, all of them did. I mean, she's been completely drug-free for the last 5 years, functioning very well. And it's just nuts that we don't do just normal things for people, actually, look at their diet and things like that before parking them on antipsychotics.
And it seemed to be a lot of your message was that, right? Like, not that the medication isn't valuable, not that the medication isn't helpful and not needed at times, but why not start with maybe some of the more, I don't know, we want to call it conventional or normal, or maybe why not start, let's just say, for diet? Why not go over that? Why not make those changes and see what symptoms change based off that before you start treating with medication that you're probably going to be on for, there's typically no pathway to get off of it for the most part. When you start a medication, a lot of my patients anyway, pain medication or any other type, and especially a lot of these like SSRIs, right? You just get put on this medication. There's not a pathway of coming off of it. You just say, start this and take it. So your message was, why not look here first?
Yep. Yeah. That's what I would say, treat it at the root cause, whether it's another drug causing a side effect, or it's food, or it could just be bread and butter life stresses, that people need support with. I mean, that's very common in psychiatry.
So why isn't it? And I get this question all the time. Why isn't it a common approach to take what you're saying, what I'm saying, and somebody goes to the doctor and they say, I have these symptoms. Why isn't it a common approach, that first step after you get maybe your blood work and your baselines, to say, all right, let's start with your diet and make some adjustments before we do anything else?
I mean, I think it rolls down from commercial incentives. So we have, to turn a profit these days, many psychiatry offices need to see, four people, a doctor needs to see 4 people per hour just to kind of make ends meet. So some of it is the insurance system and the reimbursement. And so we end up with a system where doctors feel like they need to treat patients in 15-minute visits. And when you do that, you're going to default into doing things that are quite procedural and per protocol and transactional. So it's like, well, instead of really understanding why someone is unhappy and doing a thorough history about diet, life, medical problems that can cause psychiatric issues, they pull out the DSM and they'll just say, well, you got 5 out of 9 symptoms, you meet criteria for this, because that's quick and it's efficient. And then instead of maybe doing an intervention where it's like, okay, maybe I need to do some motivational interviewing. I need to ask some gentle questions, just trying to talk to this person about maybe, patterns in relationships, or maybe some work that they're doing which isn't fulfilling, or the fact that they use food to cope with stress, or lots of caffeine and alcohol. I mean, you could do that, but that takes a lot of time, and it's a lot faster to say, well, you've met criteria for depression. Don't worry, we have this FDA approved treatment for it. It's an antidepressant. It's a way to, move people through a system in a really efficient way. And so we have a system that works well for hospitals and doctors to kind of churn people out, but it doesn't really work well for the patient. And all of this is kind of happening, while you have the pharmaceutical industry kind of looming over top, who has
Sure.
billions of dollars of marketing, which essentially reinforces that, hey, these drugs, they're really safe, they're really effective. And to even question them, you are almost dissuading people against taking them, and then now you're like a bad person as well, because you're contributing to stigma.
If you'd like an appointment, go to thespinaltruth.com and schedule today. We offer both in-person and telehealth appointments, and unlike the medical system, we look to the root of your problem. We look to find the cause, the why your symptoms are there in the first place, and we expect quick improvement. We expect improvement in pain, range of motion, or strength in the first visit, and 50% or more improvement in most conditions within 4 to 5 sessions. So if you're tired of being in pain, if you're tired of the medical system and its approach failing you, and you want something different, go to thespinaltruth.com and schedule today. Now let's get back to the show.
Yeah. No, I completely agree. I actually write this in my book that, a bad system is kind of what we've built. And I said everything that you said right there. It's 3 to 4 an hour. And if you do that for 40 hours a week over the course of about 4 weeks, you end up seeing somewhere around 720 patients, and most of the time you haven't seen that same patient. So it's 720 different patients, and how can you appropriately get to the root cause of their condition, go over with them the diagnosis, what they should do, what they shouldn't do, evaluate how the treatment's working in that time frame. And the answer is you can't, right? And if you are going to treat it, you need to have something that you can use to quickly diagnose, like what you said, some forms, and something that you can use to quickly treat, which is basically just prescribe medication, right?
Yeah, that's the only way it works. And yeah. I mean, the sad thing is, I know doctors see this. I mean, I'm on like a lot of like psychiatry network, these like Facebook pages where the different psychiatrists kind of get together, and gosh, we hate it, and the PCPs hate it, and so I think the doctors hate it. They think there's something wrong with it, but many people still go along with it because they need to make ends meet. And the sad part is, I mean, the real kind of delusion going on right now is that the patients think it's actually helpful. And yes, I'll speak to my specialty. Yes, with psychiatry, giving people drugs when they're having symptoms can have a benefit for some people,
Sure.
and they can have a huge benefit when you use it in the right person after a proper evaluation. But for a lot of people who just get parked on these drugs and they don't fix the underlying reason, the problem just festers and they just get sicker and sicker.
What would you say the percentages of that?
Say that again. Sorry.
What would you say the percentages of basically that is somebody getting parked on medication and they're getting sicker and sicker and they're not getting to the root cause? If 100 patients were going through the system, how many of them are experiencing that?
So, I mean, if I were to think out of, this is
It's a
a
tough
number of
question to
ways I
answer,
can,
right? Yeah, I'm
it's,
not trying to lock you down. I'm just trying to
no,
basically
I'm,
trying to ask how often do you see that?
well, a lot. I mean, the figure floating around in my head is that I think the only people who really get proper assessments these days are the people that pay privately. And I know that's probably a charged thing to say because we're trying to be a country where healthcare is good, that you can get, regardless of money. I mean, I think that's what we aspire to, with the insurance and Medicaid and things like that, that it should be available. But people in that system, I rarely think that their doctors have enough time to do it. So I think you might have, I don't know, 10% of people out there who have the opportunity to work with a doctor, that when they do an initial evaluation, the person sits down with them for 90 minutes and talks about their life and their diet and their history of medications, and they think, well, when did your symptoms emerge in relation to these medications? Could there be things that are drug induced? Could you be on, medications like statins or other things which may be contributing? Like that kind of deep level assessment where someone is kind of going through and really looking at you. I mean, that's something that only happens when people can pay out of pocket these days, and it's a shame to say that, but that's just the truth.
No, and I agree. And if you think about it, you said 90 minutes, right? So let's say on average, if you're in the system, you're treating one every 15 minutes. So you have to pay the price of what 6 patients would bring in order to be able to do that privately. And like what you said, most people can't afford that. But unfortunately, that's the difference between the right medicine, the right evaluation, and the system evaluation. So how
Hmm.
how did you get out of it? Or maybe is there something that was a final, nail in the coffin that for you that said, you know what, that's it. I'm going to get out of it no matter what.
I mean, there's so many things. I mean, I think, I have one really distinct memory where I was in the pharmaceutical industry, and we had just brought a drug onto market, and it had a serious side effect. Not something that would have killed the drug, but it was just something that people should really be aware of, and they should consider it. And it could be managed. And so I was in the drug safety team. That's what my role was in the pharmaceutical industry. I was a drug safety physician. I was responsible for understanding the risks of the new drugs and writing the labels with the drug companies. And our safety team, we all wanted to publish a manuscript. We said, this is a serious safety issue, and we want people to know all of the things that we've learned about this safety issue. And so let's publish something, because we've tried this drug on like 400 people now, and we know how to guide them. And then we had the chief medical officer come in and essentially just say, well, we really don't want to make a bigger deal about this than we need to. And so let's not do that. The risk is described in the label. Mind you, in the label, it's described in like, 3 sentences, and we would have done like a 10-page manuscript with actual clinical recommendations. And I get it, because and this was, and I think I already knew about industry, the way industry was for a long time. But I think that was like the moment where I was like, yeah, I really see how this works. I mean, we have a company, they have a commercial incentive. There's competitor drugs out there on the market. And if we put out a manuscript, talking about the risk of this drug, our competitors are going to grab it and they say, well, you don't want to have to worry about the risk of this drug. Did you see this manuscript that talks about it? You should use our drug. And it would essentially kind of kill it.
Sure.
And that's kind of played out, I mean, all over the country with psychiatric medications, where drug companies will market, they will put things out there to make providers see the drugs in the best possible light. They'll minimize the risks. And I remember just thinking, in that moment, I'm like, I just can't work in industry anymore. And it was crazy. I mean, my total compensation package was in the range of like $700,000. I mean, it was a stupid amount of money, for someone to be making. And that's quite normal in industry. And it got to the point where it's just like, this is awful. And I just didn't want to be a part of that. I didn't want to be a part of that anymore. I mean, and I'd always been someone going through my training when I was just like, I was questioning things. I'm like, intuitively, it feels wrong to just drug away people's emotions and tell them they have a brain problem. And that's really what we were taught. And I'm like, yeah, maybe that's the case for some people, but we're not even looking for others. I mean, we're not even spending the time to really see, how much of this is social and, other medical issues. And I just kept on looking at it more and more, and I could see that the leaders in the psychiatric institutions, the professors there, they were all on drug company payroll. Because one of the best ways to become a professor was to do clinical trial research, because the drug companies would pay for you to talk about it around the world. They would, you'd get your name on lots of manuscripts, and that's how you build a career as an academic. And so I was also just seeing, as I was going through, that there was this we'll just say there's this sort of corruption where even the leaders in the institutions which were training the next generation of psychiatrists were also kind of bought by the companies, and they had to have these very pro-drug, drug-friendly approaches, and it was just like filtering down. I just felt disgusted with the whole thing. I was just like, this is just disgusting. That no one is saying anything about it, and so.
No, yeah, I completely agree. And I had this conversation with a friend of mine the other day who's in the drug industry, and I said, "When's the last time you saw a trial that compared the drug, not just to not taking the drug or a placebo or a different drug, but compared the drug to doing something like walking 5 miles a day and getting sunlight in the morning, or changing your diet?" And it's rare. You don't see those comparisons because they don't want to give you that offer. They don't want to say, hey, you could do something natural and not something that you don't have to buy. They only want to give you, it's this pill, no pill, or another pill.
If you're out there and you're in pain, if you're tired of the current medical system failing you over and over and over again, just giving you answers that numb you, pacify you to your symptoms, and are largely based on medication, injections, and surgery, and you want a different way, maybe even a better way, look for my book, The Spinal Truth, A New World of Medicine. In it, each chapter I talk about a different symptom, different condition, different body part, and how I view it a little bit differently than the current medical system, and how my treatment has helped so many people out there when they've been let down with the typical approach. This is the way I think medicine should be. This is the change in healthcare I think we deserve. So thespinaltruth.com, you can look for my book on Amazon, Kindle, Apple, and on audio.
Yeah, they don't do that because it's you'll never see it done that way, because there's no commercial incentive. They don't even compare the drugs against like other drugs, which is, I mean, drug companies, they don't do clinically useful research. They do what they need to do to essentially play a game. So they set a precedent, and like, okay, so Prozac comes on the market in 1987 or something like that, I think then, and they go, okay, well, back then they approved the drug on an 8-week placebo-controlled trial. Every single drug company since then have done the same study, just like their drug against placebo. And there's huge, and that's just because they're playing a game to get the drug onto the market through precedent. And but there's like simple questions out there, like, how about like, how long do these drugs last for? This is a question that no one really talks about. I mean, these drugs are just like anything else. They cause tolerance. And when you use them clinically, I mean, most people will need to get the dose bumped after about 6 months to 2 years, depending on how quickly their brain adapts to it. We have no data out there that shows what percentage of people adapt to the drug in that time. And this is like useful stuff, because if you're going to say to someone, hey, you're depressed, you're going to take this drug, it's safe and effective, that's not really true, because it's going to work, but only for like, maybe like 6 months, 12 months. And then you have to go higher and higher and higher. And eventually you end up on multiple meds. And so there's these huge gaping holes in the psychiatric literature that would actually be useful for clinicians. But I mean, I worked at the FDA. FDA is kind of hopeless as well. I mean, you would expect that there would be leadership from them saying, okay, drug companies, we now need to kind of generate some more useful information rather than just playing this game to get the drugs on the market. But they don't do it. And so anyway, I'm just ranting. I hope that's
No,
okay. I've
no,
got so much to say about
it's
this.
interesting, especially from somebody that's been on both sides of it, right?
Yeah.
And I think you have a unique perspective to speak from being a part of, let's just call it the machine, and
Yeah.
then being on the other side of it. And again, we kind of have pretty similar career paths in that sense, where on my side, I'm looking at patients getting pain medication, injections, cortisone, steroids, just masking their symptoms, that doing nothing to address the underlying cause, nothing to explain the underlying cause. You have this pain, so we're going to numb it. And then what most patients don't realize is that they still have their problem, they still have their symptoms, and they keep living their life, and their symptoms are there. And once that medication wears off, their symptoms are likely worse, and they end up getting surgeries, or more aggressive pain treatment, which leads to stuff like nerve ablations or a dorsal column stimulator for pain. And all these treatments too are only interfering with your brain's perception of the pain. And they don't realize it because they're offered to them as treatments. They're not offered to them as as being what they are, which is just palliative, which is just numbing. It is literally pain management, but it's sold to you as a treatment, and it's dangerous.
Yeah, I mean, not only do they get the original problem back because the drugs wear off, now they're dealing with the side effects of the drugs. And if it's a controlled substance or something like that, your doctor starts treating you like a drug addict. They decide to cut you off. You end up in a rehab. Like, it's just, I mean, it ruins your life. And of course it would be that way. And, we do such a good job, like in medicine, convincing patients that it's not like that. And we're just like, it's safe and effective. But how could that ever work? And I'm going to go back to psychiatry now, that if you're having a problem where, let's say, for whatever reason, you constantly get into bad relationships because of some traumatic style of attachment that you learnt, in the past, and you struggle with relationships and you struggle with work, and the solution is just to like numb you to the pain of the consequences of struggling with those things, how would that ever work? For that person, or you're eating food that you're really sensitive to, and it just makes you feel irritable, on edge, anxious, and you just numb that, and you keep on eating this food that is poison to your body, which you just don't tolerate. Like, it's just, the problem is just going to fester, and eventually, I mean, you just start spiraling down. And the message to anyone who's having mental health problems out there right now, and who's on a plan where they just seem to keep on getting worse, is seriously have a good look at who you're going to for care, because that's a sign that things aren't going well. I mean, if it's just tanking over time, gradually, your plan is not working. And the doctors, they'll try and tell you, oh, your mental health condition, it's really getting severe. It's this mysterious problem with your brain that's just like, there's a whole nother level to this. Now you're treatment resistant. Now you've developed bipolar disorder. It's just like an easy way for them to explain away the fact that the treatment isn't working. And I see that a lot of the time.
I say this a lot, that you should relatively better within a relatively short period of time. Within about, in my field, 5-6 weeks of worth of treatment, you should be somewhere close to 50% better. If you're not, you're probably getting the wrong treatment, or the wrong treatment to the wrong area. And it sounds like what you're saying as well, like the proof is in the pudding, right? Like, if you're not seeing improvements, then why don't you start questioning on what you're doing and who you're getting your advice from? So if you have some advice for maybe some of the listeners where they are maybe going through some of this, and you're talking about some dietary changes, are there some maybe standards or stalwarts that you recommend to people to start with?
Yeah, so I would say, when it comes to research about diet in psychiatry, the main researched diet is the ketogenic diet. But man, that can be challenging for some people. I mean, it's a big commitment to do that. This is another thing, just to kind of link in again to how sad the state of affairs is in psychiatry. Even though there's been proof that these diets have helped people for decades, it's been, and longer than that, sorry, like, going back 50 years, there has it's only been recently that we've started looking at clinical trials into diet, and it's funded by like a wealthy billionaire family, the Basinski Group, because their son went and saw Chris Palmer, who was a metabolic psychiatrist out in Boston, and he was, I think their son Matt was diagnosed with schizoaffective, and he was just like what we were saying. He was someone who was getting worse on medications. And Chris put him on a ketogenic diet, and everything went away. And he completely recovered after, getting antipsychotics and having all of those problems. And so this billionaire family, the Basinskis, they're now funding like 10 randomized clinical trials on the ketogenic diet in different psychiatric conditions. And it's just nuts that NIH, academic centers aren't doing this work. I mean, they're all just helping drug companies develop patentable drugs rather than actual lifestyle interventions. So anyway, going back to it. So what should you do? So I think the ketogenic diet has the most information on it. You can go on my YouTube channel, it's Dr. Josef, or you could go to Metabolic Mind YouTube channel, which is paid for by the Basinski Group, and they've got a great doctor over there who talks about it. You can learn all about that diet. But in my practice, what we also just have people do is we just first, before going keto, we put them on a paleo style diet, which is a pre-agricultural diet, and so it's no processed foods, no grain, no dairy, and the grains and things like soy, gluten, and then the dairy, that it's not for everyone, but for some people that can cause it can cause inflammation. It can make people feel terrible. And the amount of people that I've seen in my practice come out of like decades of, psychiatric drug use, antipsychotics, just from stopping gluten. It's kind of crazy now that I've seen it. And so, it's not for everyone, but if you are someone that is sensitive to that, it will completely change your life. And so I would try a paleo style diet first. And then if that didn't work, I would move to a ketogenic diet. And this is specifically for people who they have anxiety and depression or bipolar or schizophrenia, and it seems like it comes out of nowhere. So most doctors, when it's like, oh, it's just coming out of nowhere, they're like, it's in your brain. No, try something dietary first. Obviously, dietary interventions, they may make you feel better, but if the source of your problem is relationship problems or work problems or something else going on, you have to address that. So the dietary stuff is
the underlying cause.
Yeah.
But if you feel like there's no reason, I've had a lot of people, and again, this isn't my world, but I'll have people that they say, I went to the doctor and the doctor said that maybe it's anxiety, maybe it's depression. And they're like, I'm not anxious. Like I don't feel anxious, but you get a doctor that starts telling you, you're anxious and you can't help but start to think, well, maybe I am anxious. Maybe I am a little depressed. And you almost start getting like incepted into taking this diagnosis and making it your problem, your condition. And I see that a lot.
Yeah. Oh yeah. Or the person who has vague complaints. They're just like, I just don't feel well. My stomach is upset. I have some back pain. And then the doctor is just like, well, maybe it's anxiety, and we get a lot of that. Like they're just like, I don't want to deal with it. It's a mental health problem. It's your anxiety. Go and talk to a shrink,
And you know what you said earlier too, where you're almost the bad guy if you're saying no. If you tell anybody these days that maybe that diagnosis is wrong, that's a hard stance to take. It's a hard stance to take, and you're not saying it's not correct. You're saying it possibly isn't correct. You possibly aren't anxious, and if they're not on that side of it, now all of a sudden this patient is irate at you, that you're dismissing their symptoms, and that's not what you're trying to do. So if somebody comes to you and they say, I have a diagnosis of anxiety, and then you're saying maybe not, that's a hard stance to take these days.
Yeah. And it's so, I don't know, there's so much propaganda out there about, anytime someone is critical about either the medications or the diagnostic system, they try and cast you in a way where you're saying that their suffering isn't real, and that's not what you're saying. They want you to come off as saying that you're saying that the suffering of these problems isn't real, and that these people are just mentally weak and they should get on with it. That's their playbook. Anytime someone criticizes them, they say, "Oh, this is just another person saying you pull yourself up by your bootstraps." But really, what I'm just saying is the drugs are making you sick. And that's what's happening for a lot of people. And your suffering is real, but it's not caused by a chemical imbalance in your brain.
Right,
There's probably a whole range of legitimate things that need to be addressed before we come to that conclusion. And yes, I do agree that there can be some people. I mean, there are some things like schizophrenia out there, and bipolar disorder, and types of anxiety and depression, which do seem to just run in families more. And some people are just born that way, and you do all of the right things and they're still like that. In those cases, for sure, let's not be kind of black or white about things, but everyone deserves the chance to get a thorough evaluation first before just telling them something that's so kind of hopeless.
Well, it's also not isolated too. There's a cumulative effect that happens in our body, and you might, by addressing the dietary aspect first, you might be setting yourself up for success when you do need to eventually take the medication. And that's something that isn't talked about as well. And that's kind of something that I'll go over with my patients too, that for me, I'm obviously more musculoskeletal. I'm saying if you address the underlying nerve issue, then maybe when you do need to go to the joint, the muscle, the tendon, now you're able to work it with more success. And kind of the same thing for you, again, in a different light, where if you make those dietary changes that had some effect on your mood, your energy level, your willingness to go out and be in public, or your ability to travel, which has, effect on your mental health, you made those changes, they helped, but they didn't get you to where you want to be. Now, maybe you need less medication in order to control the rest of your symptoms, or maybe the medication will be more effective because you also addressed another contributing factor first.
Yeah, that's totally spot on. Yeah, I mean, even if you do have a serious mental health problem, and the interventions don't get you the whole way there, I mean, it could be the difference between you taking, essentially taking 50% less of the medication because you're doing all of these other things that are helping you, and that's going to be 50% less side effects and just a better course overall.
So how long will you give it? How long will you give the approach of, and I know obviously it depends on the symptoms that you're trying to deal with. If you have somebody that is in a poor mental state, you might need to go to medication sooner. But let's say on average, how long will you give the dietary changes a chance to work or fail before you go to medication?
They work so fast. It's which is really interesting. I mean, we see changes within 3 weeks. And so I'd say if you wanted to be conservative, I would say 3 months. So if you're someone where it's like, oh, my mental health problems are coming out of nowhere, I mean, if you do something like the ketogenic diet and you try it for 3 months, that's a really good trial. I would say that most people are noticing benefits by a month. So it happens. It's not a huge commitment. It happens very quickly.
And it's what I said earlier, right? Like if you're getting the right treatment to the right area, you see results. It shouldn't, like, I completely agree with you. And especially for diet, and I call these like more like internal GI symptoms, they take a little bit more time to respond sometimes. And sometimes there's some healing that needs to occur. You get the inflammation out. You might need to give it a little bit more time to recoup those positive changes. But most of the time, same thing for me, within 3 weeks, if you're not seeing something, now I'm starting to question the treatment. Within 5 weeks, you should be seeing somewhere around 50% improvements. And if you're not getting that from what you're going through, from the treatment you're getting, from the provider you're going to, you might be going to the wrong person who's doing the wrong treatment or to the wrong area. And at the very least, you should start thinking about what else. And that provider should be having that conversation with you too, because you should expect that. I'm assuming you expect that from your treatment, right? You're expecting 3 weeks, you're expecting to see some changes. Maybe they're significant, but at the very least, there's something. And if not, now you're starting to reevaluate maybe the underlying cause, maybe the treatment, maybe it's not paleo, maybe it's more ketogenic. At the very least, you have a different treatment set up, or down the line, you have a different viewpoint saying we might need to do this if it's not effective, not just sticking with the same thing over and over and over again.
Well, one of the hard things with mental health is, and you probably see this as well, is that a lot of the drug interventions do work really quickly. And so if someone gets put on Xanax for insomnia, man, that's better in a day. If someone is on an antidepressant, that's better in a month. And so one of the really tricky things with the mental health stuff is people feel better, but then it kind of they don't realize that they start to deteriorate slowly over time. That despite being on the drug now, they're more anxious, or they're more withdrawn, or they're more apathetic, or they have lower motivation. They just don't have the drive they used to. They're not going out and doing the things that they like. And because you're taking a drug that's actually acting on your mind, oftentimes the people don't realize themselves that they're getting worse, but their spouses and their family members would just be like, yeah, he's just not the same anymore. And so it's this whole like it becomes this really confusing thing where people don't realize how disabled they're getting on the drugs as well. Yeah. And then they're just like, well, this worked at the start. And then they're just primarily set up for the doctor to be like, oh, your depression's just getting worse, or now you're treatment resistant, or you're bipolar. And they kind of gaslight you and well, yeah. Yeah. So,
and you start to think, maybe this is just me. Maybe this is who I am. Or honestly, you start having that thought, maybe this is the way I've always been. Because you kind of forget what normal felt like. And a lot of times you can't really understand what normal is until you've had a symptom completely abate. I have patients that they were in pain, or they had nausea or some form of symptom or headaches for years, and they didn't realize what it felt like to not have them until they were gone. Like even as they were diminishing, it was still in their head that they were still experiencing those symptoms. But when they finally had a day where they had no nausea whatsoever, all of a sudden they're like, oh my, that like what that difference is, what no symptoms looks like compared to even just a little bit. And they forgot that that's what normal felt like.
Yeah. I mean, I see some of the fun, the best things that I see is people regain their sense of humor. When we take them off antipsychotics and antidepressants, it's like, and you meet a new person all of a sudden who's spontaneous and will like crack jokes. And I'm just like, you haven't told a joke, and in the last 2 years I've been working with you, and now it's just like this, it's like a personality under there that comes out again.
They're lighter, they're freer, right?
Yeah, because they're not on something that's like, blunting their emotions. But there's another side to it, right? A lot of people get on these medications because they've got really, really intense emotions, which are very distressing to their life. And so what we end up doing at the Taper Clinic as well is if you're like a teenager who gets on these drugs, and then you come off in your 40s, in many ways you're learning how to deal with your emotions for the first time, since you were like a teenager as well. And so that's a whole process as well, navigating relationships off drugs. And so kind of rebuilding the person at that point, because now they haven't felt intense emotions in like 20 years.
Stunted,
and so to get
emotionally.
You could be emotionally stunted. You could also, gosh, we have some people who are just like, man, I was taking Adderall so I could do this career in finance, and I actually hate this. Now that I'm off this medication and I'm feeling well, I'm in the wrong career. Or some people they wake up in relationships and they were just like, man, this is probably not the right one, but now I have children. It's crazy. The things that happen on these drugs, because they change your personality. How could you expect any less than something that's changing your motivation, your drive, how you perceive threats and anxiety? So you just wake up and you're just like, well, the last 20 years really wasn't me or the me I am now, and now I'm dealing with that life. It's it's
a
a
lot.
really
That's a lot to deal with.
yeah, it's kind of a crazy area of medicine to be working in, honestly. I mean, it's you're getting people off these drugs after 20 years. It's really interesting.
Is there a certain condition that you see more often is maybe mismanaged or misdiagnosed, or a certain set of symptoms that you're seeing, or a cluster?
Yeah, bipolar disorder is the most misdiagnosed condition ever. A lot of the times, it's just drug side effects. You know, it's someone who got put on an antidepressant and they became irritable or they became manic. So yeah, but I mean, bipolar is probably the most misdiagnosed. And it's the most significant because when you get diagnosed with bipolar, they put you on antipsychotics and drugs like lithium that really mess with you.
Yeah,
So
heavy
it's
stuff.
yeah, heavy stuff. So yeah, I would say anyone with a bipolar diagnosis should be a little bit wary of it unless it's like textbook. Like, you know, you are manic and you're grandiose and you're like spending all this money and you think you're God. Like, unless there's this really textbook like grandiose mania, it's something that should be questioned, because a lot of the time I just see people who are irritable or who are having a side effect to an antidepressant that makes them tense and on edge just pick up that diagnosis.
Well, let me ask you this. So I see this a lot. Do you see diagnoses changing? So let's say this person, let's just say when they were 18, they got diagnosed with bipolar. What I see in my field is you got this diagnosis, and let's say fibromyalgia, right? You got this diagnosis, you accept this diagnosis as what you have and your problem. And then every doctor that you go to from there on basically reaffirms and treats that previous diagnosis. So let's say for bipolar, you go to the next doctor, you say, I have bipolar disorder. They basically now they're tunnel visioned and they're treating you for this bipolar disorder. And it just, you keep kicking the can down the line and you're not doing anything to reevaluate the condition in and of itself. You're just accepting what was given. You're accepting this label, and the patient accepts it too. The patient accepts it as them, and they don't question the diagnosis, but the doctors do it as well.
Yeah. So I mean, for many patients, they may question at the beginning, and they're just like, I have bipolar, and you know, now this is why I can't work and I can't have relationships, and they go through this grieving, and then they finally accept it and they go, okay, yeah, you know, I have to change my expectations for life. But the sad thing is when they go and see the doctors, because the psychiatric evaluation can take so much time, and you need to even talk to like spouses to understand it. No one is spending that 90 minutes to 2 hours to go back, you know, 7 years when you got put on Wellbutrin and then 3 months later you developed a manic episode. No one's putting that together and just saying, hey, you know, maybe this whole thing kicked off then, and then, you know, and then it was further reinforced that you might be bipolar because when you did try and come off the medication, they tapered you too quickly. And kind of, you know, put this history together. And so for the doctor who's seeing them in the 15-minute visit, they're going to say, oh yeah, bipolar, that's fine. Yeah, we're going to either keep the med the same, increase it, or lower it. It's like a lot easier for them to process you through the practice kind of at that level. And so, yeah, a lot of doctors won't question it because it's too time consuming for them, and then they don't get reimbursed for it.
And the only thought that goes through your mind is, how do I treat bipolar, not whether or not this person has bipolar. So you go to your playbook of, this is the typical protocol for treating bipolar disorder, and you're not questioning the underlying, you're not questioning anything. And again, I see this a lot with a whole bunch of symptoms in the medical field, but for me, it's more joint related, more fibromyalgia, CRPS, chronic migraines, stuff like that. But even joint disorders, you know, I have a meniscus problem, I have a rotator cuff problem, something like that. And it's just getting reaffirmed to whoever you go to, because it's restated by the patient from the previous doctor.
Yeah. And I mean, the other thing is, let's say you did have a doctor who wanted to spend that time. What the hell are they going to do then? Because getting people off these drugs is hard. I mean, it takes a lot of time. You need to be available for them. Are you going to be the one to sit there and teach them how to use their emotions again? Are you going to be the one to sit there and reassure them that they're going to be okay? Do you have this, you know, the support staff and all of that? They don't. because our system is simply not set up to help people come off these drugs. And so, maybe one of those doctors has tried once to get someone off the medications, and they've just been like, this is too much work. I'm never going to do that again. And so, I mean, even if they wanted to go that way, they can't do it because it's too much of a lift.
And let me put this into it too. How difficult is it for you to, I don't want to use the word convince patients, but to maybe get patients to trust you in saying, hey, it might not be this diagnosis, this medication might not be the answer. It might be a nutrition, it might be a dietary problem, it might be a gut issue. Because I have a similar approach where I tell patients that it's their spine, it's not their elbow, it's not their shoulder, it's not their knee, it's actually a spine issue. I'm telling them something that's different than anything else that they've heard. And now they have to accept this new information and trust me enough in order to try the treatment to see if it's helpful. How are you getting over that hump of going against the grain, against the, the current treatment philosophy and what the patient was told their entire life sometimes? How are you being successful in that?
So I'll answer the question in two ways. One, it never happens anymore because I am the taper clinic. We are the taper clinic. So people come to us really far down the motivation chain. By the time they come to us, they're highly motivated and they're already questioning things. But I haven't always worked this way. So, before I worked this way and I was working in a more general system, I would see people all the time who aren't ready to look at these things. And I would say, I would bring it up, and oftentimes people would, you're kind of fighting against years and decades of people being told something else by different doctors. And it's like, I struggled as well because I was seeing people in these short visits, and I mean, there's only so much digging you can do in there to really motivate them. And so I would practice against my values, especially at the beginning when I was just like, this doesn't feel right, but everyone's doing it this way. And I just, you end up just refilling the med. And I hated that. And so usually what I see happens, like, how does someone get down that funnel of motivation? The sad thing is half of the people that come through to see me are severely hurt. They've had neurological damage from the medication or from a withdrawal injury. And so it's only once they, like, everything blows up in their face where they start to question it. They go, oh, wow, I'm really hurt at the moment. None of the doctors know what's going on with me. And then they end up kind of like in that sort of matrix thing where they wake up to the world and they find themselves on internet forums with other people with drug injuries. And they'll just be like, oh, I've been, this is a fraud. I've been lied to by these doctors. And so that's one area. They end up with a drug injury. Some people catch it earlier. They wake up one day and they go, wow, I'm on like 3 different medications. And they start feeling like almost low, like some people do feel a sense of low self-esteem because innately within them, they have a belief that they're like, I want to be okay without these meds. And I don't like being dependent on the doctor, or their doctor will, something will happen to them. Their doctor will say, well, we're going to get you off your Xanax now. And they start treating them like a drug addict. They start railroading them through like a really aggressive taper that makes them feel sick. And so usually, unfortunately, something bad happens to them for them to start questioning everything that they've been told before. But until that happens, I think it's really hard to convince someone to come off.
Yeah, and again, we're in 2 different worlds, but we're kind of saying this, or I'm seeing the same thing, where you have to say something different. And you're right. If it's not the right time, if the patient isn't ready to hear it, then it's probably not going to be successful. Do you ever question why do you see it differently? Why are you sitting here looking out on a lot of your cohorts and your basically, your scope of practice, and you're saying, hey, I disagree with a lot of what's going on. Do you ever think like, are you the one that is seeing it different, or are you the one that, or what, why are you seeing it different? And how do you kind of explain that to patients?
Yeah, I mean, I've thought about this a lot. I don't think I'm alone in having concerns about the overprescribing of psychiatric medications. I mean, this is spilt out into the news, and there definitely are other psychiatrists doing this. But there's a professional risk to kind of taking a stand and saying, "Hey, I think really how we're practicing is wrong." And so there are some people who are going to be more risk averse than I am, and I think there's also like a personality piece to it. I mean, doctors, well, this is just people. This is not just doctors. I think there's also a lot of people pleasers out there. I think if you grow up, if you go through the academic setting and a professor tells you one thing, it's a chemical imbalance, these drugs are safe and effective. I mean, if you're just working in like a hierarchy, it's really easy to just be like, well, who the hell am I to question what, the endowed chair of XYZ is saying about
Sure.
this? Like, who am I? Why would I go against that? And so I also think you need to why, and this is kind of sharing maybe a bit about me. I'm a disagreeable person. I don't mind arguing with people. Conflict does not bother me in that way. And my wife is different. She doesn't like arguing with people. I mean, she would. I mean, she's passionate about some things, but on a scale of people who would shy away from confrontation, like she's lower down than I. Well, I'm more confrontational than she is, and that's just a personality. And so I also just think I'm probably a pain in the ass to deal with, and I want to understand things, and I ask a lot of questions, and it might just be my personality as well.
But you need that. You need that for change, and honestly, you need that to protect people. And if you just accept the status quo and what's being told, nothing will ever change, and you might be dealing with something that was wrong from the get-go, and you're not going to get anybody to fix it because nobody's questioning. So you need that, but unfortunately, like what you said, it's hard. It's a hard road to take. It's you might be getting backlash from your own community. You might get backlash from the patients, and you also might suffer a financial hardship during that time. Because like what you said, if you want to see your 15-minute patient and prescribe medication, it's more lucrative. It's easier to do. It's the norm. You don't have to think about something different. You don't have to sit there and question why you're doing what you're doing and how you're doing what you're doing. You just go along with everything that you've been shown, and that's an easier path.
Yeah, I mean, well, the other thing that I have to say now that you bring that up is, if you practice outside of the system, you have to build your own thing, and that's really hard. I mean, like we don't really send patients to the hospital that much in the taper clinic. And so that means that when there's an emergency, I'm dealing with it. I'm on the phone and I'm trying to keep them out as much as I can. If you're working in a traditional psychiatric setting, if there's an emergency, you just go to the emergency room, and, the system will take care of you. But if you don't believe in the system, which is what I do, we have to build our whole thing. I mean, so we've built a whole business and a whole machine to deliver the result that our patients come to us for, which is to get off medications. And it's been a huge investment. It's been very costly. I've made massive amounts of mistakes. I've wasted heaps of money doing it, just with the inefficiencies of starting something new. And so I also think a lot of people, why aren't other doctors doing deprescribing or doing something else? It's financially, it's very hard. You have to market to people. You have to know how to pick the right price. You have to build a team and all of this. And so that it just becomes this whole other beast if you want to practice outside of the system where you're building something new. And it's really not, I mean, there's no weakness to anyone. That's not for everyone. I mean,
Yeah, it's understandable, right? You can't
yeah.
blame people for not wanting to take that on. But at the same time, you're sitting there, you're
Mm.
seeing a different way, you're seeing a better way, a different approach that you would want to be more widely adopted, and you are the one fighting upstream in order to do it. And sometimes at personal cost.
Yeah, you should see the comments people leave on my tweets. Yeah, yeah.
And it's funny too, because you're not, all you're saying is, you're not saying no medication. You're saying, why not look here first? So it's very reasonable. It's very practical. And again, it might even set you up for success or less medication or better tolerance in the future. So why not do this first? But because you're saying something different, and I'm just assuming, because this is what happens with me, you get blown up by people, on social media and maybe even, people that are in your own type of line of work. They're looking at you.
Mm-hmm.
Yeah, it's tough. It's tough. Where can people go to find your services?
Yeah, easiest place would just be to go. So we have a website. It's it's Taper Clinic, TAPER clinic.com. And we're in the major US states. So, I mean, if you actually wanted to work with us, I'll list off some of them. So it would be California, Texas, New York, Florida, Pennsylvania, New Jersey, Colorado, Utah, Tennessee, Georgia. So if you live in any of those states, we may be able to help. But if you just want to learn more, like maybe you're overseas or you're not in one of those states, you want to learn about drug tapering and all of that, we put heaps of content up on our YouTube channel for free. That's probably our main platform, and it's under my name, Dr. Josef, spelt in the German way, Josef. And we have like tapering playlists out there where it's like me fiddling around with syringes and scales, showing people how to safely come off the drugs. And we do lots of interviews with people who come off medications as well, just to sort of give someone the texture of what it looks like to kind of go through these drug tapers.
That's great. I mean, it sounds like you're trying to fight the good fight. And, from somebody who feels the same about himself, I'm happy you're out there. They're doing that. I think the world needs more of it.
Yeah. Well, great. Well, thank you so much.
Yeah. Thanks for being on, Dr. Josef. It was great talking to you.